Very good. So I knew this was a great meeting of the new society, the Working Society of Echo and Cardiothoracic Surgery. So I call the talk Good News and a Challenge for Cardiac Surgeons. Can we definitively repair ischemic MR? So hopefully we'll have a little time for discussion subsequently. Talk about ischemic mitral regurgitation, beginning with its definition and mechanism, and then some good news about its prognosis, and some good news and a challenge about repairing it. So first, the definition and mechanism. I'm sure this is just a bit of review for everybody here, but it's not really ischemic. People think by ischemic we mean something that comes and goes with coronary stenosis, but it's really post-infarction regurgitation due to the structural changes that ischemia and infarction induce in the heart. It's called functional MR, relating to presumably the valve is normal in structure, although we'll talk a little bit about that later on. But it functions abnormally in the context of abnormal ventricular function. It's very, very common, that 20 to 25% of patients post-MI, and it's characterized echocardiographically by this incomplete mitral leaflet closure. Instead of closing at the level of the annulus, the leaflets are pulled down towards the apex, leaving a regurgitant orifice in the center here, and typically a central jet. So the fundamental mechanism, and we'll go into some of the proof, is that there is a change in the attachments of the valve to the rest of the heart. There's some way to get that, maybe if I use this mouse. Don't want to give people, how does this mouse, okay. Because that other one was, didn't want to give anybody a seizure. There. Huh, still, is that, is there a, oh, is that all right with everyone, or? Okay, so basically, if there is infarction in the inferior wall underlying the papillary muscle, the papillary muscle is displaced. This is not papillary muscle dysfunction, but as Carpentier calls it, is papillary muscle wall dysfunction. And because of this geometric displacement, the leaflets are tethered towards the displaced papillary muscle into this unusual configuration with a bend in the anterior leaflet where the secondary chordia insert, and not allowing the valve to close. There's also annular dilatation, so there's really displacement at both ends, and the valve is caught in this tug of war between a tethered annulus, displaced annulus, and displaced papillary muscles here. There was a lot of work. I mean, this is a summary of 10 years of work from many people and many institutions. For example, Mark Handschumacher in our institution developed a program for taking three-dimensional echo and measuring the tethering length from the papillary muscle tip to the anterior mitral annulus. And this, in a number of models, is the strongest predictor of the severity of ischemic MR. So the first way that was shown, it was in a global ischemic model that was developed by Ehud Schwamenthal, who's at Taylor Schomer here. And what Ehud did with our animal surgeon, Luis Guerrero, was to create a model of global left ventricular dysfunction pharmacologically, but preventing the left ventricle from dilating. So even with the ejection fraction below 20%, there was very little mitral regurgitation. Only when we allowed the ventricle to dilate did the leaflets become tented and regurgitation developed. And this was published subsequently with a 3D analysis by Yutaka Otsuji in Circulation. Now, Noah Liel-Cohen, who's your chairlady here at Soroka, then worked on segmental models showing the same thing. And this segmental model had actually been originally developed by the Gorman group. They created a posterolateral infarction, but early on, nothing happens. Leaflets aren't tethered, there's very little regurgitation. Only when the ventricle dilates do the leaflets tent and does regurgitation develop. So this was also studied by three-dimensional echo. The point is, you have the same amount of infarction, but it's the geometric change, not the amount of damage to the myocardium, that determines ischemic MR. Geometry is the ruling factor here, and therefore needs to be our focus for therapy. Other studies were done. Dan Guillaume did a clinical study showing that if you have patients with a low EF but no dilatation, the same as in our sheep model, you don't develop significant regurgitation. And Alex Sagi and Moti Vachuri subsequently showed the primary role of tethering in functional tricuspid regurgitation. Same physiology in a different side of the valve, different side of the heart. And Chaim Yosefi, most recently, in fact, just this past year, has published a very exciting article showing that you don't have to have involvement of the inferior wall underneath the papillary muscles. Here's an example of a patient who has, as you can see, moderate amount of regurgitation, tethered leaflets, but the inferior wall, as we'll see in the next video here, is actually, the inferior wall underneath the papillary muscles is thickening. Here's the papillary muscle. That's thickening normally. What's happening here is that the inferior wall of the apex is actually bulging out and dyskinetic in association with an anterior-apical infarction, which you don't see that well in this frame. But basically what he showed in circulation here is that if you get the anterior apical and infraapical involvement, the dyskinesis of the inferior apex pulls on the papillary muscle, and you can measure again that same tethering length from the papillary muscle tip to the anterior annulus is increased in those patients. So no matter whether you have inferior wall abnormality or inferior apical abnormality, the central mechanism is unifying increased tethering length from papillary muscle to apex. So we've talked about the mechanism. Now that gives us, later on will give us some background, the reka, for talking about the repair. But let's go on and talk about the prognosis. Now the bad news about prognosis you all know. The Mayo Clinic showed that if you have an MI without MR, you survive to a much better extent than an MI with MR. Much greater mortality post-infarction, much greater heart failure rates. People in Japan showed that this mortality is independent of the degree of left ventricular dysfunction. It is dependent independently on the severity of mitral regurgitation. Mike Picard showed that in patients with shock post-MI, the same thing. Same LV dysfunction, but if you have MR, you have a 10% survival at a year. If you don't have MR, 50% survival. If you acutely intervene, everybody gets better, but there's still a difference. MR survives a lot less. Any context, revascularization, surgical, PCI, MR, worse survival. And we know that ventricular remodeling, that displacement of the papillary muscle, can cause regurgitation, but also regurgitation can cause ventricular remodeling, and that is what multiplies the effect of ischemic MR on prognosis, because we know that remodeling is bad for prognosis. Now, here's an example of a patient. Why repair ischemic MR? A 72-year-old man, long history of coronary disease, an old inferior MI, but over 5 years, no more MI, but much worse dyspnea, exertional dyspnea. Now coming for, so here's the patient in 2005. Inferior MI, scarring, not much tethering of the leaflets, good anterior septum. Here, 2010, the ventricle is bigger. Same inferior MI, but notice that the septum here is now hypokinetic, and the ventricle is globally dilated with some more tethering of the mitral leaflets. 2005, mild regurgitation. And we know that prognostically even mild is bad. 2010, moderate regurgitation. So, what do we have here? We have the ventricle that has become progressively dilated, globally hypokinetic, with increasing ischemic MR. So this is the evolution. So even patients with mild ischemic MR evolve, and there's ventricular remodeling. Now, maybe is that remodeling just due to the infarct, or is it due to the MR? How can we separate them? Patients who have ischemic MR have an infarct and they have MR. You can't separate them by definition. So we know that LV remodeling occurs in this patient independent of new MIs. MR creates more MR. Okay, but is it independent? So Ronen Be'eri, who's in Boston now. We kind of did a switch. He'll be back next week. And Roger Hajar, who's a great molecular scientist, and Luis Guerrero worked to develop a model which allowed us to separate the effects of MI and MR. How do you do that? You take a sheep and create an apical MI. An apical MI, by and large, except in those patients that Chaim Yosefi studied where there was an infraopical extension, does not produce MR, just a small apical infarct. And then put in a surgically implanted shunt between the left ventricle and the left atrium, which creates the equivalent of mitral regurgitation, a model developed by Gene Braunwald decades ago. If you take the sheep who have the same MI but no MR, they have small ventricles in diastole and systole. But the ventricle is much bigger, this is after 3 months, in the sheep that do have MR. Not only in diastole due to the volume overload, but in systole, implying decreased ventricular contractility. And so the ventricle remodels much more with the MR for the same degree of MI in systole and in diastole. LVD-PDT is much lower at 3 months in the MR plus MI group compared to MI alone. SERCA, the basic sarcoplasmic reticulum calcium ATPase that pumps calcium out of the cells, governs contractility and electrical stability, is lower in the sheep with a shunt with the MR than in sheep without the shunt in all regions of the heart. Federico Del Monte showed that in the normally perfused zones, this is not the infarct zone, instead of having a nice rectangular myocyte, you have this long, stringy, heart failure, myopathic myocyte. So we have changes induced by the MR, independent of the MI. The MI is constant in the normally perfused zone. Cellular changes, molecular changes. As Ronen showed, GP130, which promotes compensatory hypertrophy, goes up in both groups at 1 month, but is exhausted in the group with MI and MR. AKT, which opposes apoptosis, again, goes up in both groups, but is exhausted at 3 months in the presence of MR. Very profound molecular changes. Caspase, unfortunately, which is central to apoptosis, stays up in both groups. So basically, if we have this vicious cycle in which ischemia causes decreased contractile function, LV dilatation, wall stress, and more decreased contractile function, this can be driven by the presence of MR in many ways. There's a failure of normal hypertrophic compensation. There's a decrease in contractility at the calcium channeling level. There's increased apoptosis, and there's matrix remodeling so the heart can become more spherical. Now, the good news is that we can reverse this by MR repair. Now, this model is very easy because you can just, MR repair means closing that shunt. Chaim Yosefi was also involved in that paper. So here's what happens if you let the shunt work on the heart for 1 month and then close it and follow for another 2 months. Notice without the closure of the shunt, the left ventricle continues to dilate in diastole and in systole. But with the shunt closed, the MR is small at 3 months, comparable to what it was at baseline. Maybe a little more because there's an infarction. And there are also molecular changes. That GP130, which is normally exhausted at 3 months, is actually elevated when you repair the MR, as is AKT. So we've generated a smaller ventricle, we've gone back towards normal, and generated this momentum to repair the heart, to promote compensatory hypertrophy, GP130, to oppose apoptosis, cell death. So this is a very, very good thing. By eliminating MR, we're decreasing this vicious cycle of remodeling. I should say, however, more recent results suggest that if you repair later on, you don't get the same benefit. So interrupting the vicious cycle, LV remodeling can be reversed if ischemic MR is repaired early, which is a message that I think will resonate very well with the cardiac surgeons here. The question is, how do you repair it? The other point is that, as Ronen and Roger showed, if you give extra doses of SERCA to the myocardium before you create this model using adeno-associated virus, which is shown to transfect the adult myocardium, you also get better preserved myocardial contractility at 3 months. I won't show you all the data, but it's also quite impressive compared with no treatment. So not only can you reverse the remodeling if you repair early, but also the remodeling may be limited in potential by molecular therapy, which you can give intraoperatively. There are techniques that are now well described for just putting it in the perfusate in the coronaries for maybe about 10 or 15 minutes, and you'll be able to administer these. They're actually in clinical trials already, for example. Now, what about the repair? I mean, if repairing helps, how do you do the repair? So I have some good news and a challenge for the group here. First, give an example of the current status. Why does this 75-year-old woman who had IMLC, incomplete closure, and then annuloplasty have persistent heart failure, atrial fibrillation? So here she is post-operatively. Here's the ring, which is undersized. Here's the native annulus. And the leaflets still are tethered. Normally they lie kind of flush with the annulus. Notice also the posterior leaflet is restricted in its motion because the papillary muscles are still displaced here. So she has moderate MR. So despite cabbage and a ring, she still has a lot of MR. You see, again, you can appreciate how limited the motion is of this posterior leaflet. The anterior leaflet is also restricted in both opening and in closures. So annular reduction doesn't cure the problem of papillary muscle displacement here. So here you have another patient with moderate MR after an undersized annuloplasty because the ring is only one end of the problem, but it doesn't cure the papillary muscle displacement. And this occurs in variable numbers, but 25 to 50% or more in a variety of studies, including one done with our group by Carlos Duran, who was the inventor of one of the rings. So I think we should believe him if that occurs. And this was Judy Hung and myself and Carlos. Here's an example of a patient who has a little MR immediately after the ring was implanted, but a year later has a dilated ventricle, more tethering, and more MR. Because we're not shooting at a stable target, but the ventricle continues to remodel. Now, echocardiography not only has advanced 3D imaging, but also reveals the mechanisms, so can lead to innovative solutions. And the first one that was proposed was developed with, by Dr. Noah Liel-Cohen, who's here at Soroka, published in Circulation. And that was a technique we call the Guerrero, our answer to the Batista. Luis Guerrero is a wonderful person who's our animal surgeon. He's been at the hospital for 45 years. And what he said is, he was one day doing these experiments where the ventricle, the papillary muscles got displaced, and he put his hand in there. He said, what if I reposition the papillary muscles? Well, MR went away. He said, well, I can't leave my hand in there. So how do I do that? So he said, okay, we're creating this infarction in the region of the papillary muscle, which bulges out not only this way, but also side to side. I am going to put in sutures here, into 3 rows of sutures to bring that infarct together, basically doing plastic surgery on the heart. But by bringing it together side to side over here, he's also bringing this papillary muscle closer to the anterior annulus, allowing the leaflets to relax into their normal situation. Plication procedure. I mean, it's a lot of work. You have to go through and through, use a large enough suture so it doesn't tear, and you end up with, when you look at it at the end, a smooth-walled left ventricle, out thrombi, but, and Noah followed them for 2 months after the procedure, no recurrent MR. So mechanically you can replace that, and it may be worth reconsidering this. This doesn't require a device. It's something any surgeon can do. Now, papillary muscle reposition can also be achieved by reshaping the left ventricular wall, as my colleague Judy Hung and myself and Jorge Solis from Spain have been showing, that if you can take this bulging region, place a deflated balloon over it inside a patch, echo the heart in real time, so you don't have to stop the heart, no more bypass time, blow up the balloon, watch the mitral valve until you see restored coaptation. This is a very physiologically effective way. Notice all we've done here is restore the normal shape, the contour of the left ventricle. we've eliminated that bulging of the inferior wall. This is just an example showing that in an animal model. As the inferior wall is infarcted, we're inflating the balloon, and the MR goes away. So it's individualized. You can target it to the patient. You can have a port going to the skin, so you can adjust this later on. Most importantly, you can apply it in the beating heart. Other people have done similar things. The coapsis device, which is a shish kebab thing, you know, brings the, but it's just much harder to do because you have to do this, you know, inside the operating room, make sure you're not, you know, slicing through the mitral valve, whereas the patch application, you don't need to worry about that. Most importantly, local patching reduces global remodeling. This is a treatment not just for MR, it's a treatment for heart failure. Okay? And this was shown not by our group, but if you look at the Gorman's group in Philadelphia, they created an inferior MI which continues to dilate over, you know, doubling, more than doubling end diastolic volume over 2 months. If you put in a ring, it continues to dilate, but if you, even if you just patch it without a balloon, the ventricle has a much blunted rate of dilatation. Miguel Chaput in our group showed this with MRI, that if you put a patch, this is a control sheet, and you put a patch on, first, the size of the infarct itself is smaller for the same vascular territory. Secondly, the size of the ventricle at the same phase of the cardiac cycle is smaller. So you decrease global left ventricular remodeling. You can see that here. The rest of the ventricle is pumping quite nicely. Here's the patch over the infarcted inferior region, which is no longer bulging. It's not contracting, but it's not bulging outward. You can also do this by injecting polymer into the subpapillary muscle region, as Judy Hung is doing now, and this is without the polymer, and with the polymer getting rid of the MR. So the good news is that you can actually restore a normal alignment between the mitral valve and the annulus with relatively simple techniques. My challenge will come at the end. One thing before I get to that final thing is giving you a glimpse into where the science is going. We know that essentially ischemic MR is a mismatch between the ventricular size as it dilates and remodels and the valve size. If the valve could grow as much as the ventricle, there would be no ischemic MR. The question is, does the valve grow? So our current thinking assumes the size of the valve is fixed, but as we published in Circulation in 2008 in patients, using Mark Hanschemacher's three-dimensional programs, the valve is actually larger, up to 35% larger in patients who have inferior or global left ventricular function. The problem is it's not large enough to prevent ischemic MR. So does the valve grow? Well, when we asked Alain Carpentier how to study this, he said, first you have to study tethering itself without MI, and then see what effect MI has. So Luis Guerrero again took the papillary muscles and stretched them out in the absence of MI, tethering the leaflets here, and the valve does actively grow. There's cell growth. There's, as you can see, there's increased thickness of the valve itself. This is a normal valve. This is the tethered valve after 2 months in the beating sheep heart. The chordae are thicker. The leaflet is thicker, less transparent than the usual thin leaflet here. You can see that the valve looks thicker as well, and there's an induction of cell growth. Normally, valves grow by having the endothelium become activated, express smooth muscle actin, which allows the cells to become contractile, and then they dive down into the center of the valve to create more valve tissue. This is exactly what we see in sham-operated sheep. We have no smooth muscle actin in the endothelium. In stretched sheep, after 2 months, we have activated endothelium with smooth muscle actin with cells diving down into the interstitium to create this enlarged, thickened valve. If you add MI, and I won't show you all the data now because they're not published, you get a markedly thickened valve, but also the precursors of fibrosis and thickening, which is probably not a good thing. Now, I know Dr. Boris Orlov is here, and he's done a lot of pioneering work to try to increase valve area mechanically, and I expect he'll be talking about that too. But this is where the future is going, to try physiologically to improve valve size. But for the moment, So the message of all of this is the valve is dynamic. It has the capacity to reactivate early growth processes. I'd like to propose this challenge for repair. We have this basic problem in ischemic MR. If you look at the literature, you have many studies that have variable results about if you do a CABG and a ring, what is the benefit in terms of mortality and quality of life. I think no one will challenge that quality of life is better. But what about mortality? The problem is that, as we saw, that the ring is not necessarily a durable, long-lasting therapy for ischemic MR. So we can't tell whether mitral valve repair improves outcome if the mitral valve is not repaired. So if you have 25 to 50% of patients who still have MR long-term, how can you judge whether that repair is improving outcome? There is a randomized controlled trial going on in the US, sponsored by the Heart, Lung, and Blood Institute, in which patients with moderate MR are being randomized to CABG versus CABG plus ring. Those with severe MR to ring versus replacement. But these are the old therapies. What about the new therapies? What about therapies that are targeting tethering? We saw that tethering length is the key to ischemic MR. None of those are targeting that tethering problem. So my challenge to you, and I know that now you have an organization, Dr. Liel Cohen has created a network of researchers across Israel who've already published several papers. And now by gathering together as echocardiographers and surgeons, the challenge is this time to revive plication or other simple procedures like putting a patch in a balloon so that you could do a clinical trial of old techniques versus targeted, more effective techniques and test for the first time in an Israeli setting whether this improves prognosis. So that's my challenge, and hopefully this will generate some controversy and maybe some enthusiasm. So thank you very much for your attention.